Let's start. Um, Dr. Nihaal, shall I start? Dr. Nihaal, can you hear me? Shall I start?
Not sure he is able to hear us. I'm not sure what's the problem.
Yeah, I cannot. He's not responding. No?
Ma'am,
Huh?
please start.
Okay, sure. Yeah. So this is a 5-year-old boy. So at 6 months of age, he had had meningitis. Then he was treated about for 10 days with antibiotics, a little bit of cells. No, nothing came out of that. Then 1 month later, he had a seizure, and that time he was taken to a different hospital in North Karnataka, and he was diagnosed with Rad-aid. He received steroids, and following this, he had global developmental delay. So I think I met him once at when he was about 4 years back, when he was about 1 year old. So that time he had come with dyskinetic movements, and they had told me that every illness he has these dyskinetic movements, and then when the illness gets better, he also gets better. So I thought LRID may not explain everything. So I asked them to do genetics, and then they didn't like that idea, so they disappeared. But 2 months back, they came back to our hospital because he had a severe episode of chorea, following which he was thought to have seizure. I'm not so sure. It may have been the chorea only, and it just continued. So he was treated like status epilepticus, and then that time he had influenza. He recovered from it. However, the dyskinetic movements continue to persist, and before this illness, he father showed me a video. He was able to look at father, he was able to respond to him, and he was even able to sit without support. But after the illness, he's had a bit of regression. And now he has very severe hyperkinetic movements, dystonic posturing at the ankles, oromotor dystonia, and there is some intermittent nystagmus as well. I noticed that father also has nystagmus. After the MRI, after the most recent MRI, so I think we have three MRIs. They asked us to do serum copper and ceruloplasmin, which were all normal. LFT was normal, and ammonia was also normal. Urea was high. I think he was dehydrated because of the oromotor dyskinesia. He was not able to feed properly, and so he was advised to do NGT feeds, which they were not happy with. They gave it for a week, and then they only removed the tube. So that's where we are with him. We've got some genetic test result now because after this episode, father consented for the genetic test. And so we wanted to discuss whether it's acquired or whether it's genetic or what can we do about these movements. So,
Uh,
yeah.
Sir, not audible. Nihaal, sir.
Nihal, you are not audible.
Still inaudible, sir.
We can't see a microphone only on your thing, Nihaal, on your profile.
Perhaps, Dr. Rashmi, I mean, you have seen all the images. You may give a comment, perhaps, to save time and continue and go to the genetic test.
Yes. So I think he has put up the first scan, which actually shows Alarid, which you can see in the scan. And then he will probably show you the latest scan, which shows that the brain has shrunk completely and there's a minute
We can't see the scan now.
Yeah. I don't know what else to comment. Do you want to know the genetic report?
No, but perhaps Anas or whoever is responsible can share the screen.
Why not encephalitis, ma'am? Yes, he may have had encephalitis. First time, I think he was treated like encephalitis meningitis only, first month at the age of 6 months, and 1 month later it was Alarid. Let's see.
And you move on.
Dr. Amina, can you go through the scans? Dr. Amina is our pediatric radiologist, and she's also doing neuroradiology. I think you're a panelist, no, Dr. Amina? Can we have Dr. Amina as a panelist?
Is this slide visible?
The slide is visible, yes.
But can you enlarge?
Can we have Dr. Amina as panelist? Can anyone make Dr. Amina a panelist? Dr. Anas, Dr. Razi, can you make?
Should I move the slide forward?
Huh? Dr. Razi, can you make Dr. Amina panelist? Dr. Nihaal is visible now. Your video is visible.
Let's check. Am I audible now?
Oh, you're audible at last.
Okay, all right.
Okay.
Anas, I'll take over. Thanks.
Yeah.
So, okay, these are the first images, set of images, I think, from 2020, if I'm not mistaken. Is that right, Dr. Rashmi?
Yeah, 2020, correct. October 2020.
Okay, so
We can't see the screen. Just
now?
you.
Oh, okay. I think Anas is sharing. Anas, are you sharing by any chance or?
Okay.
Okay. 1 minute. Now?
Yes.
The screen, but
Okay.
not that scan, the first scan, 2020 scan.
Got it. Yeah.
Yeah.
Right. Okay.
Yeah, that's the scan, yeah.
All right. So October 2020, this was the first scan. As Dr. Rashmi mentioned, that diagnosed it as possible ALERD, given the confluent changes of the subcortical cytotoxic edematous abnormalities in the bilateral hemispheres. All of them do not restrict on diffusion. I mean, do not show reverse on ADCs, but majority of them demonstrate cytotoxic edema. So predominant peripheral changes involving the bilateral hemispheres. Some areas of patchy abnormalities in the bilateral basal ganglia. So these were the main findings on the diffusion and ADC sequences in 2020. T2s did not demonstrate any significant findings other than what we have seen on diffusion, maybe some degree of cortical volume loss in the frontal lobes, but other than that, nothing significant. And no enhancement on the post-contrast studies. These are just attenuated vessels because of the edematous changes in the bilateral hemispheres. I'm not sure of the timeline of this scan, Dr. Rashmi. There was one interval scan.
Yeah, so this scan was done, I think, 1 month later.
Okay, so 1 month later, I put up only the T2 sequences. And you can appreciate there is progressive cerebral atrophy in comparison to the first study. There were no changes in terms of diffusion abnormalities there. So I think these are expected changes for an alert pattern. If you consider the alert pattern of a 1 month scan demonstrating this progressive volume loss. And was the child on any medication at that point of time? Dr. Rashmi, steroids or
No. Steroids was only one course was given in that October 2020, that ALERD.
Okay.
After that, no following immunosuppression thing.
Okay, fine. And then we have one more, the most recent scan done in September 2025. That is now 5 years into the first study. Anything in between recurrent dystonias or dyskinesias is what you mentioned, I think, previously.
Yeah, there is no scan in between that one and
No, in terms of the clinical presentation.
clinical presentation. See, dyskinesias were there even beginning also, but they would be with illness, like a viral illness, and they would go away.
Okay.
But this time it's just persistent. It's been like now he got admitted, I think, in around August, end of July or something like that. And up till now, he's still having the dyskinesias.
Okay. All right.
Persistent.
So previously, the cerebellum did not demonstrate significant changes in terms of volume changes, but now also the cerebellum has demonstrated reduction in volume of cerebral atrophy out there. And you have this extra the supratentorial changes we've seen previously, but now there is progressive volume loss. You can appreciate the extracodilatation of the lateral ventricles, possibly some patchy hyperintensities in the basal ganglia and thalamus, and also in the pons, as you can see on the midline, which is already appreciated on the flare SAT sequence out there. These are T1 non-contrast sequences on top. You can appreciate there are punctate T1 hyperintensities. Some of them demonstrate corresponding blooming changes on the SW sequences, possibly some mineralization or calcification present in the bilateral basal ganglia and the periventricular, and also some areas of juxtacortical regions on the pedicilvian regions and also the temporal parietal lobes. Spectroscopy, this is an intermediate spectroscopy, I think, done at T144. The peak which stands out corresponds with a lipid peak. Usually, if it's a lactate peak, it should invert, but this has a broad-based lipid peak around 1.2 to 1.45 parts per ppm. Rest of them do not demonstrate any significant abnormalities, at least not what I can appreciate. Post-contrast sequences do not demonstrate any enhancement. These hyperintensities were there on the non-contrast T1 sequences, so these are not enhanced, not to enhancement. I think then, based on this progressive changes and recurrent clinical symptoms, genetic study was done. And Dr. Rashmi, over to you.
Yeah, so genetic study has come up with 2 genes. One is KMT2B, heterozygous, which can cause dystonia and childhood dystonia and all that, and ATP1A2, which may not necessarily fit in because it's polymicrogyria, dysmorphic facies and all, which he hasn't got. So
yeah, And the other one was NCDN.
NCDN, correct. Yeah, that was.
Infantile spasms. In terms of imaging, I think 81, 182, as you mentioned, polymicrogyria, but these are usually alternating hemiplegia kind of disorders. We have these
183.
183. Okay, yeah, sorry. So yeah, so I get that. So yeah, at least the imaging doesn't match of that gene. No polymicrogyria in our case. And then the KMT2B, they have known to be associated with globus pallidus changes, but our child had more neurodegenerative progressive changes, which I don't think again matches specifically with this gene.
And the clinical course does not
Yeah,
fit.
it doesn't match. The things I thought of possibly imaging wise, if those are calcifications, we don't have a CT. Whether it fits into any of these except the Labrun syndrome, I don't think it fits into ACADs. Imaging wise also doesn't maybe fit into ACADs. Maybe cocaine. I don't think child has the clinical features of this spectrum. So it's a neurodegenerative disorder with some degree of brain iron or calcification and progressive changes over a period of time, and the recurrent clinical symptoms. So I would favor more of a genetic. I was thinking more of a genetic than acquired insult. The case is open if anyone has any suggestions.
I think the question was whether it is secondary to the post-Alerid, this much of atrophy and mineralization, or whether there's an underlying genetic or metabolic disorder which is causing this.
At least Alerid, I don't think mineralization, even if it's dystrophic in nature. Yeah, I mean, I've not seen that associated with Alerid. And the recurrent symptoms, does it persist after a single point event?
Symptoms have persisted, and this time it is really bad. Like this time, this illness, the symptoms have not reversed at all. Normally with illness, few days he has it and then he reverses back. But this time it has not reversed at all. So
he have microcephaly?
Sorry, microcephaly is not there. No, there's no microcephaly.
Because Consire can also have the subcortical changes and basal ganglia changes, calcification and all. But
yeah, the syndrome is not. I mean, yeah. Ophthalmoplegia
Say-
and hearing loss, cardiac abnormalities.
any mitochondrial thing like TARC1, Consire or
Lactate levels were checked in the illness. It's been normal. Lactate levels were normal.
How old is the baby?
Sorry, sir.
Now,
How
the
old is the
baby
child?
is now 5 years.
Now 5 years old.
Yeah, so nuclear genes also can give rise to mitochondrial most of the times in young age, and they don't follow the usual Kern-Sayre syndrome and all that in young babies. So those are for the mitochondrial inheritance in older children. So I think this could be a mitochondrial disorder. Just because lactate is normal doesn't mean it's not.
Okay. Does it, any of those genes will fit in? No, not really. None of those genes, right?
Not really, but then mitochondrial disorder also half the time you don't get a gene for it.
You say it could be. I mean, this is hypothetical. They're not really very strong arguments. And the problem is you have probably some double trouble. You had an encephalitis or meningitis in the first week, and then this alert. So the history is not a clean history.
Correct. Yeah, that's why we brought it up here. Because whether it is like in between, they also saw Dr. Mahesh Kamte sir at North Karnataka, and he seemed to think that this is all post-Alerid sequelae. That's what he was telling. So
Question of MOG was done by Jayant. MOG variant.
MOG was done. MOG wasn't done, I'm afraid.
Okay.
I'm sorry I came a little late. So after the newborn period or the early infantile period, he keeps getting worse every time he gets illness.
Yes, that's right. That's the history.
Yeah, but that's very difficult to accept with alert. Why would that happen so often?
Correct. That's why I had asked for genetics about 4 years back, because that's the history they gave, that every illness, he gets a little worse, but then after the illness, he gets better. That's 6 months. Yes, Dr. Anas. At 6 months, he had the encephalitis meningitis. And then 1 month later, he had the Alerid. Dr. Amina, you're not yet panelist, is it? Dr. Amina said, in her opinion, changes secondary to LRAD should have been most pronounced in areas most affected by LRAD. Basal ganglia weren't that involved. The mineralization is also along the falx. So is that something? And Dr. Amina was saying something about the skull thickness being too thick or something.
Skull thickness on the scan, skull thickness.
Hi, sorry.
Yeah,
So the skull, hi everyone. Skull thickness, I think, is just secondary to the atrophy. So yeah,
but
that's not relevant. The other thing that's what I meant by what I wrote was I also favor a little more of genetic cause. Because LRAD, those areas in the white matter, LRAD had mostly spared the basal ganglia, while the changes now are mostly in the basal ganglia and in the hippocampi, a little bit of tectum and these areas, not that were involved first in the LRAD. So I favor genetics as well. Thank you.
yeah. All right. Thanks, Amina.
Yeah, so how should I proceed? Now, I've put him on a lot of medications. I've also put him on mitochondrial supplements as well. I don't know, symptomatic treatment is what he's on now. So
The child has recurrent illnesses or recurrent symptoms just because of random trivial illnesses?
no, because of the illness, he's had this dyskinesia, which has continued
Okay.
after the illness. Normally, he has it for a week or a couple of weeks and then it stops.
Okay.
This time, it has just continued. So I have
No
him on
immunodeficiency.
symptomatic treatment.
Immunodeficiency, would that be considered?
No, he's not got recurrent illnesses.
Okay, got it. Okay.
After the illness, he gets the dyskinetic movements, which normally resolve, but this time it has
CSF the first time?
CSF, no, CSF was done on the when he was 6 months old and that encephalitis was there, but recently I have not done CSF.
Was it normal?
No, that time there were some 20 cells or something like that. They had not picked up any organism at 6 months of age. Then 1 month later, he had this other MRI which showed LRAD.
Yeah, but LRAD is, just a descriptive term. We don't know the etiology. No storage disorder symptoms, right?
No,
In
no
terms
other.
of-
No, there's no hepatosplenomegaly. No, there's no other story.
It's not really a disorder. It's even so.
Sorry.
Amina has chronic valproate atrophy, yes, but was the child on chronic valproate?
No, child has been on valproate from the day one.
Okay.
Yeah.
Okay.
They've been on valproate for a very long time. Valproate will not cause so much shrinkage of the brain, right?
Yeah, it's more phenytoin kind of.
Valproate can cause cerebral Of course, this is a bit too much.
There's a lot of atrophy, is right. Is it worth doing anything more to dig out which mitochondrial disorder, like skin biopsy or something like that?
Parental testing won't help, right?
Parental testing I'm going to do. I'm going to advise
Okay.
because they have one more child. So I'm going to advise parental testing and to meet the geneticists. These two I will advise. But I was thinking if anything more.
If you don't have a good suggestion, we might suggest to have a wait and see loop for some months and then reconsider the situation again and see whether these kinetic movements disappear or aggravate. It's not very constructive, I realize.
Yeah, I know. Yeah, I can understand. Yeah. And that's what I told father. We're going to treat you symptomatically. So because of the oral dyskinesia, let's have the NGT in or gastrostomy, but they were not willing. They said they'll feed him every 1 to 2 hours somehow. But let's see.
Okay.
Yeah, sure. Thanks.
Right.
Thank you very much.
All right.
Okay. The second one is a 7-year-old girl, normal development, and she had just had one episode of focal seizure from sleep lasting for 5 minutes. And her MRI was very interesting. So, and we had some debate about it.
EEG,
So I put it.
Rashmi?
EEG, I'll tell you 1 second. I think EEG showed some focal changes. I don't recollect exactly where.
Okay.
Yeah.
But only isolated a single event, it seizures without febrile illness.
Correct.
And no other clinical presentation up till now.
Afebrile seizure, no other thing.
So normal up till now.
Yeah, just
No
one
need-
seizure, developmentally
Okay.
normal child. EEG was
Okay.
not showing what is that, centrotemporal spikes. That much I remember,
Okay.
but nothing more than that. So
All right. So the main finding is a left pre-rhonic region or precentral gyrus, and you can appreciate. These areas of I would call this as gliosis. You can appreciate the widening of the cortex out there, and also there's a transmetal line running through. There's no change on diffusion various sequences. That's the corresponding diffusion. And again, you can appreciate on the T1 inverted sequences, there is, again, you can appreciate the thinning of the cortex, especially out here with the widening of the circle space. No contrast enhancement. I did not have an true SWA sequence, but only had one MIP image. Possible prominence out there of the medullary vein, but yeah, cannot be very sure of that. So the main question I think was, is this gliotic foci, or is it a silent or malformation or focal cortical dysplasia? Is that right? Okay.
yeah, that's right. Yeah, that was the main question. Yeah, that is a thing which everyone had raised, whether it is.
It's a malformation. It's a sulcus dysplasia. And you have this kind of tract from the bottom of the sulcus close to the ventricles.
But the atrophy,
So
again,
you know, similar changes you see sometimes in therapy-resistant epilepsy. So unless you get hold of this is a candidate for epilepsy surgery.
Oh, really? Okay. See, her EEG just showed occasional sharp waves. Okay. Overall, it was near normal. Occasional sharp waves were there in the, I think frontocentral region. It was overall near normal, her EEG. I thought this was very deep.
I think in the literature it's called the bottom of sulcus dysplasia.
yeah, but they usually not associated with the Julie gyria or cortical, atrophy type pattern. I thought it's more along the medullary veins, and there could be some sequelae of an insult out there. And these are the changes which I have now demonstrated on the present scan.
Gliotic scars.
Yeah, that's what I thought.
Autonomous sulcus dysplasia, yes, there should be some thickening, there should be some focal gray-white matter interface abnormality, and then you may have a tail going to the cortex. Yes, over here there's an actual loss of volume, there is no thickening at all.
There's one birth history, Nico admission with fever for 6 days, but nothing more than that. Yeah, little bit of a birth history is there.
Yeah, at least I would call this as a star or genetic change, but if the child has recurrent seizures, then maybe.
Gliotic scar can be a surgical candidate, but not right now anyway. Single seizure.
So you would say that this is more scarring? Would most of the panelists say that this is more scarring?
That's what I think, but I may be wrong. It's just that I think it's there.
See, because they said it's focal cortical dysplasia, I don't normally start treatment until second seizure, but then I started treatment for this girl because I thought better to start if she has that. Is there any evidence of DVA, Dr. Nihaal?
Not on the contrast. Not sure if this is a prominent vein out there. But I don't have the true SWA sequence. I only have the MF image.
Rashida says treatment is needed for sure.
Yeah, I think he means medical treatment. I mean, is that
yeah,
right?
ASM. So ASMs are required because chance of second seizure is more than 60% because
Exactly.
of normal EEG and MRI.
So anti-seizure
I
medicine.
also feel it's more of gliosis.
So gliosis is because you're thinking it's thin, is it? The cortex is thin and not thick.
Yeah, the cortex is thin. There is a eulegiric overall above eulegiria is present, and the transmental sign of FCD is not this white. What I have seen till now, this is too white. This looks more of a scarish thing rather than a transmental sign of FCD.
It was reported as FCD type 2 by our.
And with NICU history, I'm pretty sure that this is a scar only because some hypotension he might have had, and this is an watershed area. I'll go with the scar.
Okay. I think most people are going with a scar, right?
We'll go with the scar, Dr. Ashmi, and we'll wait and watch if the child is not responsive to medication. But yeah, it looks, I mean, CD I would have expected to be thickened rather than thin.
Yeah, someone's
PET
asking.
MRI, I don't think we have PET MRI. Do we have PET MRI in Bangalore?
We have PET MRI, but I don't routinely do
I'm
it.
not sure. Yeah.
I mean, yeah, okay, I'll see how she goes clinically. If it's a scar, they should be reassured because, you know, as she grows older, maybe she'll get better also. So, yeah, we'll see how she goes clinically and see. Thank you very much.
Oh, thanks. All right, Nihaal, over to you.
Good evening, everyone. So this is regarding a 12 years old boy with normal birth and development. He presented to us with complaints of reddish eyes, which was on and off since last 2 years on medication. And there was, since the last 2 months, there was difficulty in walking and squatting. And he had calf pain also only while walking. And this was somewhat subacute onset, gradually progressive. And there was also nocturnal enuresis, and he had complaint of straining for emptying his full bowel and both bowel and bladder. And this was increasing in severity since the past 10 days. And his past history is significant. He was admitted at around 4.5 years of age, diagnosed as Pyri-ITP. He presented with multiple ecchymatic patches over his face, bleeding from nose. At that time, there was thrombocytopenia. So, treated as Pyri-ITP. IVIG, steroids, and Dapsone was given. So, on examination, when he presented to us, he had a bilateral conjunctival congestion, and there was decreased power in the lower limbs, proximal more than distal. Every moment there was power was around 3+/5, and his deep tendon reflexes were exaggerated. Plantars were extensive, and his gait was somewhat mild right-sided limping gait was present.
Anything other than the gait, Vishal?
Yes, nothing only.
Okay. Okay.
So with this paraparesis and bowel and bladder symptoms, we initially thought of some spinal cord pathology. But it turned out to be something.
Okay, so you did the investigations after the scan or before the scan?
After the scan.
Okay, so we'll maybe come.
Dr. Nihaal, the conjunctivitis, I think, was being treated by the off-time people as allergic conjunctivitis. They didn't find any signs of uveitis at that point.
Okay. So you want me to show the labs now, or?
Please go ahead. Yeah.
Okay. Well, yeah. So, so this is we have T2 axials. I think on FLAIR the findings are better appreciated, but on the T2s you can just see that there is some degree of parenchymal volume loss. Some patchy hyperintensity is possibly in the cortex out there, and also in the brainstem. But in the FLAIR has a more definitive picture. So these are the FLAIR non-contrast sequences, and you can appreciate that there are multifocal abnormalities involving the white and gray matter structures. You can appreciate that around the parasagittal regions, including cingulate cortex. You have involvement of the centrum semiovale, the presylvian cortex, subinsula white matter, and also some areas of involvement of the anterior mid-basal ganglia, the postcentral thalamic nuclei, the peritrigonal regions, basifrontal cortex, medial temporal lobes. Again, you have insular cortical involvement out there. inferior temporal lobe involvement, and also brainstem involvement, and some areas of involvement of the vermis. These did not show any area of restricted diffusion. I have not put that up. Also, you can appreciate there is some optic pathway involvement involving the tracks and also the memory bodies. On the F-sub-based sequences, there were no areas of corresponding changes of blooming of the areas involved. Contrast did not demonstrate any significant enhancement, no meningeal enhancement, no cranial nerve enhancement. The pituitary stalk appears to be normal. There is no thickening of that visceral supracellular structures, and no parenchymal enhancement of significance. This is a SAG T2 non-contrast sequence. Not sure if I have the axials, but I could not appreciate any focal or long segment abnormality. And these are post-contrast sequences. Again, I'm not able to appreciate any significant enhancement out there. I think at this point of time, clinically, the thought was that this is a demyelinating spectrum disorder, or this chronic autoimmune disorder with multi-system involvement. And with that presentation, I think the investigations were done. So Vishal, over to you.
Yes. It's a routine investigation, CBC, CRP, RFT, LFT, CPK levels, urine routine were normal, and ESR was mild elevated 40 mm. D3, B12 was normal, TB workup was normal, CSF routine was normal, serum, CSF MOB, NMO, and oligoclonal banks were negative. Direct Coombs test was positive 1+, and in view of neurobase, we sent HLA-B51, it was negative. And we thought of something chronic autoimmune chronic condition. So the panel was sent ANA immunofluorescence was positive 2+, and SLC 70 was 1+, mild positive. But clinically they were not matching. He had no rash, joint pains, no skin lesions. They evaluated it as bilateral resolving uveitis with allergic eye disease, and he was on topical medication, tacrolimus and olpatidine.
Okay, so we're thinking more of autoimmune spectrum disorder rather than inflammatory antibody rate, as we have mentioned already, the antibodies are negative. So I'll open the case if anyone has suggestions which autoimmune disorder it fits into or which connective tissue disorder. Shrida mentions possibility of neuro-SLE or monogenic lupus. Okay.
dsDNA was negative, and I think the renal workup was also okay, unless it is just isolated CNS. Because I think we couldn't explain the atrophy. I mean, even though it was mild, there was no reason why he should have atrophy unless it is something vasculitic process which is going on.
Did he have hypertension?
No.
No.
He had short stature and paleoarthritis. Weight for age, height for age centiles were less than 30.
HIV?
I think it was done previously. That was negative. His entire surgical profile, pre-surgical profile.
SLE is one of the another suggestion. Congenital SLE, Manas.
Would it present this late? I mean, his first presentation was like a ITP at 4 years, and then a long gap.
An autoimmune panel sent
Yeah, it was sent, I think 2 or 3 times. Once it was sent during that, I think ITP time it was not sent, but from the rheumat side, before he presented to us, baseline was sent. And then because we thought Bechet could be a possibility, because there was one remote history of oral ulcers, but he doesn't have recurrent oral ulcers.
Okay. Yeah, at least the imaging clues would have been some form of hemorrhagic changes or vasculitic changes, focal abnormalities.
Hey, have you done this thing, immunoglobulin level?
No, I don't think we did that.
Yeah, I think you should do that. If the eosinophils are high and if there is hyper IgE, then hyper IgE syndrome, one of the variants presents with autoimmune hemolytic anemia with A1 syndrome like presentation, and then can involve brain later.
We won't get anything on the chest X-ray and all, like with the eosinophilia, high eosinophilia. Sorry?
Yeah, so one of the hyper IgE syndromes are DOC7 or PGL3 gene. They do have this presentation, but I don't know. It looks one of these immune errors of immunity. Basically, that is the spectrum we are dealing with here. One of the
Okay.
differentials. One of the differentials, not the only
Okay.
thing.
Okay. No, because I was only thinking that sometimes the hyper IgE type syndromes, like they sort of present with recurrent infections, skin and chest infections, and they can have like osteolytic lesions also.
Yeah,
But
so
I'll look into this
hyper
later.
IgE, but yeah, it is a IEI basically. That's what my thing was, because subacute onset, a previous antibody mediated or immune mediated thrombocytopenia, DCT positive, ANA2
Yeah.
plus,
Yeah.
subacute course and relapsing remitting with other
Yeah.
acquired backup being negative, then IEI is one of the possibility. So
Okay.
that's what the chat also feels, I think.
Okay. Okay. Thank you.
Right. Normal eosinophils, yeah, as Vishal has mentioned, no ulcers, no dry eyes. Unless there's possible organs, CH50, skinning can be seen. Yeah. Changes appear to be in the subacute or chronic stage on imaging at least.
Could it just be two separate events? And this is just post-viral or something?
Yeah, imaging wise, I would say it can be possible, but I would have to take in the clinical presentation into consideration.
The only thing is that sort of lesion near the decussation tracts, is that what is explaining his bowel bladder involvement, and the probably his sensory tracts are also affected, and that is why he was having pain. Because there was no spasticity, even though because he was having the pain only when walking. He was able to sit cross-legged and everything quite well when he was on the bed.
Yeah, possibly because spinal cord is, I mean, almost completely normal. Yeah. Unless mentions background of failure to thrive, yeah, so it's a chronic process which is ongoing. So post-infectious, I wouldn't say, but I would take into consideration of the clinical picture and maybe test for, as mentioned by Sridhar and others, for chronic illness.
Sure. Thank you.
Thank you, sir.
Right, Razi, over to you.
Good evening. So, hello.
Yeah, go ahead.
So this is a 11-year-old girl, born to secondary consanguineous parents. Around 9 months of age, he presented with thrombocytopenia, for which initially thought of ITP. Over a period of 3 months, bicytopenia was evolved, considered as Ivan syndrome. And then later, around 7 years of age, she had multiple cervical lymphadenopathies. And for which biopsy was taken and suggestive of Hodgkin lymphoma multicellularity, and child was treated with ABVD protocol. Later, again, around recently in December 2024, again had relapse of Hodgkin lymphoma, for which protocol was changed, VCOPT protocol was started. And in past 1 year, she had multiple infections requiring multiple hospitalization. In July 2024, she had septic shock and LRTI requiring mechanical ventilation. Then in August 2024, she had UTI with pancytopenia requiring IED and CCFS infusion. as well as in Jan 2025, she had severe success with LRTI requiring IV Nihaal prednisolone and IVL. So in SPET 2025, she had difficulty in using upstairs, using upper limbs for 3 days and difficulty walking for 2 days. Which was gradually progressive weakness of her. She was unable to eat or bath by herself, unable to walk on her own, and gradually she was unable to sit unsupported as well. Background history, she had motor delay with proximal weakness. She was having difficulty going, unable to run and bathing herself. She had these difficulties.
That Sitapal.
All right, go ahead, Raji.
During this time, on examination in Feb 2025, extraocular movement with bilateral mild abduction restriction was there. Some ophthalmoplegia, appreciate bilateral facial weakness, and neck flexor and extensor weakness with power of 2/5. And both proximal was more affected than distal with the power of 1/5. And placid hypotonia with BPR were absent, and bilateral contractures, PA contractures were there. So this was the first episode, in which he had acute onset of placid quadriplegia, axial, as well as proximal more than distal weakness, on the background of proximal muscle weakness. So initial possible differentials at this point were possible localization was muscle or neuromuscular junction or metabolic, we thought of in muscle, metabolic causes or electrolyte disturbance like hypokalemia could cause this weakness. Yeah, child was evaluated with serum electrolytes and RNST, NCS was done. NCS and RNST was normal. She had a severe hypokalemia. She was given potassium correction. After this, there was significant improvement in her proximal weakness. She was able to do anti-gravity movements post-correction. CPTs were normal during that time. Ultrasound abdomen, KV, ABG, and urine electrolytes were done, which were normal. And later, he had relapse in December 2024, for which VCOP protocol was given, and she went into remission, and she was planned for bone marrow transplantation. So, haploinsufficiency from father, transplantation was given.
Anything here, Raji?
After transplantation, 14 days later, engraftment was there, and 20 days into the transplantation, child had severe, again, worsening of proximal more than distal weakness, both upper limb and lower limb weakness. And 3 days later, he developed a severe frontal weakness and neck flexor weakness, unable to take, and recently had pooling of secretions and respiratory muscle weakness. During that time, CPKs were repeated, which showed a significant decrease in CPK, 760. And by the time frontal weakness, it was 3,561. So she had SIADH with severe hyponatremia, for which 3% MS connection was given, as you can see. And then a date of tolvaptan was given. Post that, she developed, kalium was normalized, but she had hyperkalemia. Serum osmolality, urine osmolality was supportive of SIADH initially. For this, after treatment, she went into hyperkalemia, and thus muscle weakness has progressed significantly in her case. And CPKs were increasing. She was on cyclosporin initially for GVHB prophylaxis. Then post that she was shifted to sirolimus. And on ultrasound, muscles were done, all of the muscles, which showed normal in bulk, but increase in lipotexture in muscles were there, all of the muscles. So MRI brain and spine was done during this time.
Anything here, Raji?
And other investigations were worked up. Bone marrow Viral PCR was negative, CMV, EBV, IgM were negative, and fungal infections were negative, being exposed as negative. Immunoglobulin levels were normal, and during the course of illness, he had multiple organisms positive from 2017 to 2020.
Okay. Before moving on to MRI, can you just summarize clinically what is the what are you thinking in terms? Or do you want me to show the MRI first? Okay.
So progressive.
Got it. I think we'll come back to that after the MRI. So MRI, I think we have two sets of MRI, if I'm not mistaken. So this is on the August 2025. We can appreciate cerebral and some degree of cerebellar volume loss, but more in the supratemporal brain. And this multifocal tiny abnormalities, likely chronic in nature, involving the cerebral white matter on both sides. Mild caloric thinning, but yeah, the main changes on the T2s and the pairs are chronic changes in terms of parenchymal volume loss and some multiple focal abnormalities. These did not demonstrate any restricted diffusion, no SWA sequences, no blooming on SWA sequences. Contrast study did not demonstrate any significant parenchymal or extraxal meningeal enhancement. Spinal cord was done, and these are the spinal cord changes. No spinal cord abnormalities in terms of in the cord, but as you can appreciate, there are significant extensive abnormalities in terms of fatty degeneration of the muscles, posterior paraspinal musculatures extending from the cervical to the lumbosacral region. Also, you can appreciate the other muscles also demonstrate atrophic changes and fatty degeneration. You can appreciate the upper limbs out here, the shoulder blades, and also the gluteal musculature, iliopsoas region. So there's diffuse atrophic changes with fatty degeneration of the muscles, and these are the stir non-contrast sequences. And you can again appreciate that there is edematous changes of the muscles which are present, demonstrating stir hyperintensities. So there's a background. There's a combination of some intramuscular edema along with chronic changes of fatty degeneration involving the paraspinal musculature and also the entire body, visualized body, especially the upper and lower limbs, and also the midline torso and the gluteal musculature. So I think based on this, I think we sent for a genetic testing to look for any congenital disorders. Yeah, Razi, what do you think?
Yeah, genetic mutation showed SPIN1 mutation, which was homozygous and local pathogenic variant immunodeficiency. They can also have microtubular aggregate myopathy, which was very severe in her case, with proximal muscle weakness and external ophthalmoplegia. Usually they don't have ptosis, but they can have meiosis and proximal myopathy.
Yeah, so as Razi mentioned, it correlates with our case, child had recurrent infections and cytopenias, persistent high CPK levels, liver dysfunctions. And on imaging also, if you look, the predominant changes in the extra neuronal system, especially the musculoskeletal system, they present with the progressive changes of fatty degeneration, also associated with intramuscular edema. So the imaging wise also it matches. And as pointed out, the gene targets immunodeficiency, myopathies, and also stroke-like or stroke syndromic changes. So it's a match in terms of imaging wise, and also I think clinically also, I think it's nice. Any specific question here, Razi, or any experiences with this gene for the panelists and the audience? Yeah. Anyone has any experience? I mean, seen these conditions? All right. Yeah, we just wanted to share the case, see the extensive involvement of the muscles, and also the clinical spectrum, immunodeficiency, myopathy, and other systemic features in this case. All right, Razi, over to you.
So this is a 15-year-old boy born to secondary consanguineous parents. Initially, around 5 years of age, he had total illness and he had outside deviation of right eye. An examination had partial third nerve palsy and cerebellar signs were there, some ataxic gait and pyramidal signs were there. And based on initial symptoms and MRI was done and suspected demyelinating viral encephalitis kind of picture, and child was given a course of steroid as well as antiviral was started. Initial CSF analysis was normal, CSF lactates were normal, and meningoencephalitis panel was negative.
All right, I have a very pixelated scan, I think 10 years back, almost 10 years back. And here you can appreciate, not sure if you can, there's a focal abnormality in the midline brainstem in the midbrain out there. Also in the medulla. On diffusion, these were the main findings. On the flare sequences, you can appreciate there's some ventral hyperintensity around the medulla, some brainstem pontine hyperintensities, and also hyperintensities involving the optic tracts, mammary bodies on the flare sequences. So these were the main findings, at least on these images. Yeah, again, you can appreciate the diffusion changes out here in the midbrain and also in the medulla, along with the optic pathway, optic tracts, and the mammary body abnormalities. All right, 7 years later.
Yes, 5 years later, he had left-sided hemiparesis and increasing walking difficulty was there, but he came to us in Jan 2023 with severe headache and behavioral changes. During that time, repeat imaging was done, and post that, investigation for small vessel vasculitis was done.
Okay, we'll come back to the. Now again, you can appreciate there are new focal abnormalities in thalami on both sides, more on the left side. Possible some chronic changes in the left inferior cerebral hemisphere. You can appreciate there's some gliotic foci out there. And also there's reduction in the volume of the anterior basal ganglia causing extraocular dilatation of the frontal horns. So some chronic small vessel ischemic changes seen with some degree of parenchymal volume loss more along the cerebellum rather than the cerebral hemispheres. Diffusion did not demonstrate any recent or acute changes in terms of ischemia. Angio did not demonstrate significant stenosis, but I think there was some degree of tortuosity. Yeah, no steno-occlusive disease, but maybe some degree of tortuosity of the anterocerebral arteries out there. Yeah, after Razi.
Yeah. So based on that small vessel vasculitis kind of thing, because the child had right flick and right quadrate, right flick involvement and right quadrate atrophy as well. And AMA profile, Pianta, all vasculitic workup was sent, which was negative, and genetic workup evaluated for DADA 2 as well. Initial genetic workup was negative for both sides. Then in August 2025, he presented with acute onset painless loss of vision in left side for 5 days, only able to appreciate hand movements close to left side. An examination, he had left RPD and left ICRA. And he had baseline left-sided hemiparetic gait. So MRI was repeated during that.
Okay. Yeah, as Rajesh mentioned, the primary consideration thought of was primary CNS vasculitis, and also monogenic vasculitis. DARA2 was tested previously called for a export-related genes, also given the recurrent ischemic and vasculitic events, and also background of consanguinity out there. And this is the most recent MRI. Again, you can appreciate several volume loss of the anterior basal ganglia, some chronic gliotic changes in the anterior basal ganglia, and also the brainstem. And corpus callosum thinning, especially the anterior mid segments. There was no optic nerve edema on either side, and on the MR angiography again, I did not appreciate any steno-occlusive disease or vasculitis pattern. So there is, and on the established sequences, yeah, you can appreciate some tiny areas of blooming. These correspond with hemosiderin deposits in the basal ganglia and also the plus cerebri on the right side, substantia nigra. And also in the left peripheral region, we appreciate this foci of abnormality, which are likely corresponding with chronic hemosiderin foci. So volume loss, small vessel ischemic changes, chronic in nature, and some decrease of hemosiderin foci in the most recent MRI, and no contrast uptake or enhancement. Spine was screened. I don't have access to images, and there were some spiral hyperintensities of the cervical cord. These are likely, I think, artifactual. In terms of enhancement, again, no significant change of enhancement. Again, genetic testing again was done after this scan, and
again, it was done because of strong suspicion of the other two molecular vasculitis, which came as the pathogenic variant in our case, and ADA2 total ADA2 activity percentage was also reduced. There was accumulating deficit over 10 years period. First time around 5 years, presented with right-sided partial optic ophthalmic third nerve palsy, and second episode with hemiparesis, and third episode with left eye CRA.
So clinically, it's a match. As demonstrated in neurological symptoms, the main CNS findings, I think, multifocal ischemia. Child can have hemorrhagic changes also with other systemic conditions. And I described these are the main neuroimaging findings of DARA2 mutation, especially when there's recurrence. Think of and child has hemorrhagic stroke-like lesions or hemorrhage with smaller ischemia. A possibility of DARA2 mutation is to be raised. Yeah. So that's the case. If anyone has any comments regarding the case. So.
There was improvement in vision. He was given a steroid dose, and child has been started on adalimumab currently. TNF alpha.
Yeah, Anas points out CRAO is rare, but has been reported in DARA2. So yeah. All right, general comments. So we'll go to next case then. Apura, how do you?
Yes. So this child is a 3-month-old girl. She presented with developmental delay, motor more than cognitive. She attained rollover at 7 months, neck holding at a year, pull to sit by 2 years, and pull to stand by 3 years. And currently her best motor milestone was cruising around furniture. She had early right hand preference and asymmetric tightness of the limbs on the left side, more on the left side was noted. Cognitively, she could recognize parents, eye contact was there, fixing, tracking, no hearing issues, socialization was also appropriate to the cognition. She had some pseudobulbar dysfunction, swallowing issues more for liquids than solids. So she had motor more than cognitive delay. 3 months of age, she had only 1 episode of fever-triggered generalized motor brief seizure lasting for 1 to 2 minutes. Thereafter, there was no recurrence. Antenatally, there was significant history of urine infection in mother 3 to 4 times during the entire antenatal period, in early as well as in the last trimesters. And she was born of 3rd-degree consanguineous marriage, 3.5 kg. She had delayed cry at birth and an ICU stay for 2 to 3 days, had poor feeding, but there was no hypoglycemia documented, and she was discharged after day 3. Again, on day 40 of life, she was readmitted for poor feeding due to retrognathia, as told by parents, and neonatal sepsis requiring admission for a week. On examination, child had microcephaly, 45 centimeters. She had diffuse skin ichthyosis. There was dysmorphism, wide intercanthal distance, smooth philtrum, retrognathia, some gaze-evoid nystagmus, hypopigmented non-familial hair, low anterior hairline, callosities over feet because of the way she was walking, and fixing tracking was there. Spasticity was the predominant motor finding, adductor, hamstrings, and gastrocnemius, and there was contracture at bilateral hamstring and fixed contracture at left gastrocnemius, but there was asymmetry in the findings. There was hyporeflexia and distal wasting, and there was axial and paraspinal weakness. So this is the child having significant dysmorphic facies as described, wide intercanthal distance, retrognathia, and a broad root of nose. You can also see in the limbs, there is bilateral severe ichthyosis kind of feel, but she didn't have any abnormal smell on examination. And there is significant distal wasting as compared to the proximal muscles. So this child was not evaluated, and this sibling is an 8-month-old baby. This child is completely having no motor development and no cognitive development. And this child also has now started to develop, has the similar dysmorphism like wide intercanthal distance, broad root of nose, retrognathia, smooth prominent philtrum and smooth upper lip. And if you see, even this child has started developing ichthyosis, just like the girl, and more livido reticularis and some suffusion of the skin. So for this child, some neuroichthyosis syndrome was considered Jogren-Larsen or some phenotype. But based on the scan, we wanted to discuss other differentials. Genetics is not done.
The imaging of the elder sibling or the younger one?
Elder sibling. Younger, they have not evaluated.
Okay, so I'll just put up the T2 sequences. I think these were the more representative findings. You can appreciate that there's malformed cortex in terms of polymicrogyria involving the bilateral hemispheres, especially the frontal and the peripheral regions, but more on the right side. There's some asymmetry of the cerebral hemispheres, especially on the right side, and you can appreciate the sulcation pattern also is slightly more significant in terms on the right side in comparison to the left side. Yeah, so malformed cortex, especially frontal and peripheral regions, right more than left. These are the main findings. I don't have a SAD to see the corpus callosum midline structure, but I think it appears to be slightly thinned. Yeah, so these are the main findings, and we wanted to check if it's any neurocutaneous syndrome, whether to evaluate for any genes or possible mTOR pathway related disorders or polymicrogyria related disorders, or any mosaic. Yeah, sorry.
NCS was done for this child, for the elder sibling, because of absent hyporeflexia and absent ankle jerk. So that child has sensory motor axonal neuropathy. But the younger child has brisk reflexes and more, like both have spasticity, but this girl has now developed spasticity with peripheral neuropathy and cerebral dysgenesis polymicrogyria. So one phenotype which was fitting was Sedgwick syndrome that has neuropathy, has polymicrogyria and spasticity, but any other differentials. Genetics has been sent, but any clinical and radiological differentials.
As the younger sibling had imaging, I may have missed the point.
No, this is the only imaging I can. This is of the older sibling.
I mean, some intrafamilial variability is not unusual, but it seems from the photos and your description that these siblings have the same condition.
Yeah, the clinical phenotype looks similar.
Yes.
So genetic investigation makes sense.
And yeah, Sedgwick has mentioned as polymicrogyria as the main cortical malformation. So if it fits into that, yeah, all the possibilities.
We haven't done copper in celloplasmin. We have advised them, so they have yet to come with the reports.
Dr. Viveka's says ELO-VL4 defect, serine deficiency. I'm not sure if malformation is there for them. For Sedgwick, it's a good possibility. Jayan says even Mednick. Yeah, so Sedgwick, Mednick. Yeah, I think we'll have to wait for the genes, the genetic test. Okay, so I think we have two suggestions: Sedgwick, Mednick, as one as two possibilities.
What is the age of the child in the scan was done?
This is 3 years back. Let's see what is.
Oh, very early. Okay.
7 months.
Yeah, very early.
Yeah.
Yeah, infantile age.
From the academic point of view, the MR of the younger sibling would be informative, but perhaps this is not possible for financial or psychological reasons.
Right. So we thought once we get a genetic report, based on that, we can get a scan and then think of matching the two.
Okay. Please enlighten us with the gene whenever you get it. Then we can maybe match the phenotype.
Right.
Thanks.
So this is a case, 5-year-old girl who was born to a non-consanguineous couple, second in birth order.
How old is it?
Yes.
Came with
Yeah,
complaints
go
of
ahead.
developmental delay. So she started walking with support from 3 years, and currently at 5 years, she was able to walk independently. At 3.5 years, she was able to scribble and do fine motor activities, self-feed herself. Speech was severely delayed, just 2 words, and predominantly pointing-based communication. Cognitively, her understanding by 5 years, he was understanding some colors and indicating toilet after she had done. She had 2 episodes of focal impaired aware motor seizure. At the first was at 3 or 10 months of age, and the second one was at 5 years when she first came to us. So this child also had very peculiar findings. She had dysmorphism, very prominent frontal head. She had alopecia, and there was wide intercanthal distance, broad root of nose, and there was bifid tongue with some lingual frenulae like findings within the tongue. Also, you can see there was a syndactyly that is seen in the thumb and very short hand, short fingers. There was no rhizomalia, but the hand was short. Next.
The digit look like macrodactyly. Is that just on the photo?
No, she had microdactyly, short fingers and short feet.
No, I'm talking about macrodactyly of the thumb. The thumb on the photo appears very thick, but maybe this is just on the photo, the right hand.
She has syndactyly. There were 2 thumbs.
I think this is the nail, if I'm not mistaken.
Yeah, the
Is
other
it?
nail.
Okay.
Yes.
Okay. So syndactyl.
Yeah. While walking, she had some wide-based gait. So for her, the scan was done and the genetics which was done outside, which was discordant. So we wanted to discuss.
Okay. Scan is not of the optimal quality, but at what age again? At 3 days of age.
This is 3 days of life.
Okay. Again, you can appreciate some asymmetry. We'll go from top to bottom. Some asymmetry out there in terms of the cerebral hemispheres. The left one is slightly smaller. It causes the FARCs. There's possible polymicrogyria, especially on the left frontal regions. I'm not sure if there's subcortical heterotopia on these images, but definitely malformed frontal lobe. Corpus callosum also deficient. I think SAG will be better to point out that finding. Coming to the posterior fossa, you can appreciate that there is some thickening and elongation of superior cerebral peduncles. There's some dysplasia of the vermis and hypoplasia of the cerebral hemispheres on both sides. Yeah, SAG images again not very clear, but you can appreciate. I'm not able to appreciate a corpus callosum, or maybe there's a thin corpus callosum out there. But it appears to be an agenesis of corpus callosum, and there's interhemispheric cystic changes because of deficiency, especially on the left side. So malformed cortex, especially the frontal perisylvian regions, more on the left side, there's some asymmetry of the hemispheres, agenesis of corpus callosum, and posterior fossa findings, especially of the cerebral peduncles and the cerebellum. Based on that, I think genetic testing was done.
Yeah.
And
So
these were the genes.
Right, sorry.
Yeah.
So outside the WNT5A was Robinow syndrome they had reported, but the MRI matched with Robinow syndrome is not there. They may have skeletal and craniofacial abnormalities. KCNT2 doesn't look like. We were considering because of the molar tooth and the polymicrogyria, Varady-Papp syndrome as one of the clinical because of the skeletal abnormalities, polydactyly, bifid tongue, and she also had lingual frenulae and with the MRI changes.
All right.
Is that a kind of hemimegalencephaly?
The malformed area is actually reduced. I mean, so I would say maybe not. Usually, the megalencephalic hemisphere is more malformed than the normal one. I'm not sure if this is subcortical heterotopia or a brain malformation kind of a picture, especially over here with some polymicrogyria.
Doesn't look like Varady-Papp classically. Varady-Papp can have hypothalamic hematomas. They have some precocious puberty or something like that.
And the supratental malformation, I'm not sure if I've not seen such an extensive abnormalities in the IDPAP.
No, they don't fit. The supratentorial finding don't fit to Varadi-PAP, which is orofacial digital type 6, which is a subgroup of Joubert syndrome spectrum. This is far beyond, I think.
So for this child, actually, the genetics which was done, the correct handles were not given, the radiological and the clinical. So currently, we have added all of these radiological findings along with the clinical findings, and then we have sent for a reanalysis. And maybe if required, we might go for a. Will repeat imaging help in this case, because the scan quality wasn't very great? If it adds,
If it's still a VUS, then maybe yes, the reanalysis, if it doesn't match. Now the child is 5 years, right?
right.
Yeah,
I think repeat imaging is not really helpful in terms of finding a defined diagnosis.
Yeah, we'll have to wait for the reanalysis.
I wonder whether a mosaic could explain this in the pathway of AKT3 or mTOR or whatever. So this would be perhaps considered to look in a skin biopsy.
Right.
So we'll wait for the reanalysis, and then maybe think of as Dr. Poddar mentioned.
We'll do the reverse phenotyping based on the gene that we get.
All right. I think that's the set of new cases, but I have 4 or 5 follow-up cases which we'll quickly go through. The first case is from Nikesh. Nikesh, if you're there.
Yes, sir.
Yeah.
Yes, sir. So this is 7-year-old child presented with history of fever. Once episode of fever in the month of June. Second was also in the month of June. That was associated with thrombocytopenia, and mild splenomegaly was there, along with hyperferritinemia, hypofibrinogenemia, hypertriglyceridemia. So at the time, possibility of HLH was considered, secondary HLH, and child was given injection meropenem, injection methylprednisolone for 4 days. Fever got reduced, child was fine for 1 month. After 1 month, child again presented with fever episodes. At that time, thrombocytopenia was persistent. So on the 2nd August, child was undergone bone marrow aspiration with biopsy. That was normal. But the new complaint emerged, that is in the form of headache, mainly in the frontal and occipital region, along with vomiting. So from on the 6th August, the child was investigated in the form of MRI, which showed cerebellar edema with periventricular ooze. ANI profile was negative. CBC was at the time it was normal, and all the investigation which were abnormal in the initial period, that became normal. So from 6th August to 26th August, child was having intermittent episode of headache. But on 26th August, child presented with severe headache along with right-sided torticollis for 2 days. And for the same, child was admitted and MRI brain was done on the 26th August.
Okay, I'll take over now. So this, just to quickly recap, these were the initial images I think we discussed a couple of meetings prior. And as mentioned, there was cerebellar edema along with some degree of obstructive hydrocephalus demonstrating this periventricular interstitial edema. So that time we thought that no corresponding hemorrhage or blooming on the S2S sequences, and no area of significant enhancement. That time we said the imaging was pretty non-specific, but the suggestion of cerebralitis and the causes were varied, not typically fitting into HLH picture in terms of imaging. Possibly immune-mediated was considered, but generalized cerebralitis with related secondary changes because of the edema and causing hydrocephalus. As mentioned, a biopsy also was done, and I think at that time a biopsy was awaited. And then I'll just come to the follow-up and I can take over. So at that time, HLH we did not wasn't suggestive, especially on imaging of typical HLH type features. Biopsy was done, and the biopsy showed, the comment was lymphohistiocytic disorder, unlikely to be LCH. HLH cannot be ruled out completely. And this is the follow-up scan done, I think last week or a couple of days back. And you can appreciate there's a progressive change, especially in new lesions involving the supratemporal brain, the white and gray matter structures, predominantly the white matter. But the posterior fossa, you can appreciate now the changes, they appear more patchy, look like more like a HLH type picture in terms of the extensive area of cerebellar involvement. Decompressive craniotomy was done after the first scan because of the cerebralitis. In terms of diffusion, mixed pattern of diffusion changes, some patchy areas of restricted diffusion, but predominantly a facilitated diffusion was seen. Again, supratental abnormalities, the left external capsule demonstrated this area of restricted diffusion. SWS sequences, there were some hemorrhagic changes. I think mostly posterior hemispheric or cerebral hemispheric are mostly post-operative. And the left subinsular change demonstrated these areas of punctate hemorrhage. Contrast enhancement, supratentorally, there was no significant enhancement, no cranial abnormalities, some patchy areas of enhancement in the cerebellum on both sides. Again, I think testing was done looking at the imaging. We raised the possibility of HLH, and this came out just today. So, do you?
Yes, sir. So this was sent at the initial admission on the 1st of September, and it came out to be PRF1 gene mutation, and it was familial type 2 primary HLH.
So the imaging now matches, I would say, rather than the first scan. Do you want to just show the follow-up and the genetic? Yeah, if any comments, open to it. But Colin asked only CNS was involved. Okay.
Yes, sir. Only CNS
Okay,
has been involved.
Yeah. So yeah, primary familial CNS. Right.
Initially, some multidisciplinary involvement was there at that time, but later on only CNS.
All right, so that loop has been closed. To our next case, not sure if Harika is there, but I'll just quickly run through. I think this was again discussed a couple of months back, and this was a 9-year-old child presented with one episode of focal motor seizures and also had a history of right hemiparesis in May. Who was admitted on.
Nobody else can wear it also. Nobody else can wear it.
Yeah, so yeah.
Too big for
okay, yeah.
Too small for you.
Okay, 9-year. Dr. Rani, or you can just move yourself.
Dada's tummy is bigger than
Sorry.
Yeah. So 9-year-old child, one episode of motor seizure, admitted and later discharged. And this was the imaging at that point of time. On the flare sequences, you can appreciate confluent, almost leukodystrophy type pattern changes in the cerebral white matter. They are predominantly involving the white matter, deep brain nuclear structures, the brainstem, cerebellum were relatively spared. You can again appreciate the same findings on the T2-weighted sequences. And on post-contrast, you had these focal enhancing lesions involving the cerebral white matter. That point of time, the CSF was done, and we had thought of possibility of a demyelination, particularly MOG-related demyelination or MOG-led leukodystrophy type pattern. Other considerations, I think, were genetic, but we are more going towards a demyelinating spectrum. Testing was done, and the child came out to be positive for MOG antibody related disorder. Child had a follow-up scan. This is 3 months interval. The images, I can maybe there is some mild reduction in, especially in the anterior frontal and the posterior right posterior periventricular peridiagonal region, but you can again appreciate that there are significant residual abnormalities in terms of the confluent changes. Anas, any idea what treatment the child was on in between, if you remember the child? Or Razi? I think immunomodulation was given, if I'm not mistaken.
So this child is on oral prednisone also.
Okay. Yeah, so leukodystrophy-like pattern, we just wanted to point out that possibility, other than genetic disorders, we can also think of MOG-related disorders, especially in the appropriate clinical setting. Yeah, so that was the follow-up on that case. If anyone has any comments.
How old was this patient?
I think 9 years.
Yeah, but the leukodystrophy pattern is usually described in young children, has a really bad prognosis, which is a little odd.
The age was little, above, usually less than 5 years is what we see the leukodystrophy type pattern. Harika, what was the mock titer? Let's see.
The titers we didn't get, so it has given us positive, moderately positive.
Okay.
Actually, positive means more than 1 in 100. This was 1 in 10, right? So you can't be sure.
Yeah.
But the way he responded could be anything else.
Yeah. Okay, we'll see if we need another follow-up scan, maybe in 6 months' time. Okay. To our next case, Harika, you want to take over quickly?
Yes, sir.
Yeah, go ahead.
So this is 12 years old boy born out of non-consanguineous marriage with history of non-progressive painless loss of vision since last 2 years. There was no worsening or improvement in vision in last 2 years. There is difficulty in identifying for objects, and there was history of headache that was relieved by vomiting once in 2 months. And when the child came to us on examination, extraocular movements were full, pupils were bilateral equal reacting to light. And on visual acuity, right eye distant vision was 20/50 and near vision is N08. And left eye distant vision was 20/50 and near N10. And on optic disc examination, there is diffuse disc failure. And motor examination was normal. For this non-progressive painless loss of vision, we have done neuroimaging initially.
Okay, so initial neuroimaging, we thought that there was compressive neuropathy of the optic nerves, narrowing of the optic nerves, resulting in tortuous optic nerve and optic sheet diameters were dilated. CT, that time we discussed, there was mild calvular hypertrophy. I can appreciate that on the bone window, also involving the jaw bones, the maxilla and the mandibles. The formats did not show any angular abnormalities of the jaw, but you are having these systemic abnormalities in terms of sclerotic changes in the rest of the bones. There's almost like an early manifest abnormality of the metadiaphysis out there. And we thought that there's possibility of osteopetrosis causing these optic neuropathy and these changes on the skeletal survey. Genetics was sent, and the genetics came out. Yeah, sorry.
Genetics came out to be like CTSK, that is cathepsin K enzyme mutation, like compound heterozygous involving exon 4 and 5, that is pycnodysostosise, autosomal recessive type with VUS. But this phenotype, according to literature, they will be having like short limbs, short stature, and also craniofacial abnormalities. But our child is craniofacial.
The obtuse jaw is a typical finding for pycnodysostosise. Acryosteolysis also wasn't there in our child. So we wanted to check if the gene matches or we need to reassess.
Yes, sir.
Yeah, angular mandible college wasn't obtuse for our child. Yeah, so the angular mandible is not obtuse. There's no acryosteolysis. Yeah, so I think radiologically it's not a match, Harika. At least the typical findings of what we see in dysostosise is not there. And as you mentioned, clinically also it's not a match. Is that right?
Sir?
Or not a complete match, no, clinically?
Yes, sir, not a complete.
Okay.
No, sir. Only these thickened bones.
That sclerosis is there, but yeah, other findings are not matching.
So should we go for analysis?
I think, yeah, you have to go for parental line.
Yes.
Did you contact an expert in skeletal genetic osteopetrosis? or a consortium to see whether this really does not fit or whether it's an option? I mean, we know that not every patient fulfills all the criteria listed in OMIM or in the clinical synopsis.
I agree, absolutely.
Okay, sir, sure, sir.
Genetic disorders are so many different varieties, and you may have so much of phenotypic variations. I'm not sure you can exclude it. The most important thing is the bony, the X-rays.
We'll look into that. Okay. Yeah. Last two cases. Not sure if Dr. Shikha is there, but we had a confirmatory diagnosis for this child. For this child, I'll just briefly summarize. Was a 15-year-old. Scholastic performance was above average, but started to deteriorate, I think, last year onwards. Child also had some psychiatric issues, had atypical behavior over a period of time, and then the child was kept on, also had some form of selective mutism, clumsiness, drunken gait, skin picking, was kept on medications of, I think, SSRIs for a few months. With this background, I think they were looking for any psychiatric conditions, but given that the autoimmune etiology to be ruled out, I think the MRI scan was done. And on the MRI, I think we discussed this a couple of months back again. Is bilateral cystic changes in the basal ganglia, some of them demonstrating hemorrhagic abnormalities, possible calcifications, and fluid levels with peripheral enhancement. That point of time, I think germ cell tumor was one of the possibilities raised. The labs were suggestive, but I think the child underwent stereotactic biopsy, and the father had confirmed yesterday. I don't have the report, but over phone, he had confirmed that it had turned out to be positive for a germ cell tumor. Yeah, so we just wanted to highlight this changes. I think usually they are unilateral basal ganglia abnormalities, but this child has bilateral basal ganglia abnormalities and also cystic changes, which has to be kept in mind for a germ cell tumor given the psychiatric presentation, and over a period of time they can have cortical volume loss, severe atrophy. If anyone has seen bilateral changes, I think I couldn't find that in the literature. So
we had one patient who actually had a germ cell tumor on one side. It presented actually with hemiatrophy, and after then later on the germ cell tumor on that came, and then a few months later on the right side as well. So it was
the atrophy hasn't completely set in, but they can appreciate some performance. But bilaterals at the same point of time was what.
Anybody know why this occurs? Why does the hemiatrophy occur? I couldn't really. And sometimes it precedes the germ cell tumor being found.
Yeah.
Okay.
I think something had to do with thermoparticle connections.
Possibly, yeah.
Yeah. So that's just disrupted earlier, and there's hemiatrophy. So that's the case, and I think the last case, this was from Wade. I think we discussed this on the last meeting. Dr. Dani, you're aware of this. So this was a 7-year-old child, had prior infection, then in the neonatal period, and then in October 2024 presented with seizures, hemiparesis, facial palsy. And these were the imaging. I think there were a couple of imaging done for this child. You can appreciate that the child had more right-sided abnormalities with cystic changes in the bilateral hemispheres, bilateral posterior hemispheres, and some degree of leptomeningeal enhancement was there on the initial scan. Child was given acyclovir, treated for a possible viral infection. CSF PCR HSC was sent, came out to be negative. MRI was again repeated. The child became symptom-free. But on the MRI, you can appreciate that there was progressive changes in the right side, more on the right side than left. And then in July, again, the child presented with headache and vomiting with focal seizures, and the serum NMO MOG was negative. Biophiles were negative. So this was the follow-up scan, and you can appreciate again progressive changes, both hemispheres, but more on the right side. And we had this nodular enhancing foci of the leptomeningeal and glial changes on the right side. At that point of time, we had suggested for the child to go ahead with biopsy. for the lesions, suspecting a possible HSV granulomatous necrotizing granulomatous changes. Yeah, contrast again. These are the significant findings on the contrast sequences, glial and left range enhancement, thickened enhancing pattern. So biopsy was done, and the biopsy they had given us a report as of necrotizing granulomatosis, granulomatous inflammation. The antigen was, I think, sent subsequently, which came out to be negative for HSV, but not a neoplasm. And yeah, the biopsy, they had concluded it as necrotizing granulomatous inflammation, raising the possibility of a chronic granulomatous herpes encephalitis. Yeah, so that's the tissue diagnosis of this case. We don't have HSV. Is that completely excluded out, Dr. Nani, or is it just that it's not active at this point of time? Or any other test to be done?
PCR as well as there were no inclusions either. So
okay, so it's a granulomatous inflammation, but of unknown cause at this point.
But it could be some trigger, and God knows. So
Yeah.
we're putting them on steroids and the short course of acyclovir, but I don't think we're giving it continuously. I think that somebody else was giving continuously, right? So I think that was finally decided. Thank you.
Yeah, thanks. That's our last case. If there are no further comments, we'll conclude the session. Apologies for the technical issues in the beginning, and we'll make sure we are on track. A couple of weeks later, on 10th of October, please send in your cases by the 7th of October. Till then,